I'm Lee Kelso, host of the HealthCall Live Radio Hour. Glad that you're here. Obesity is a significant health threat in the nation. There are new medications that are available and that can make a significant difference. So why aren't they more widely available? That is a concern of today's guest, and she is Dr. Fatima Cody Stanford from both the Mass General Brigham Hospital in Boston and also Harvard Medical School, one of the nation's few fellowship-trained obesity medicine specialists. So let's jump right into that issue. What's going on? Why aren't these meds more widely available?
Well, I think it goes into really this key issue that we have, and that's the recognition of obesity as a disease. Unfortunately, very few people, when I talk about few people, that's starting at the healthcare system all the way down to the patient level, recognize obesity as a disease. We see it as a failure on the part of the patient to eat less and exercise more. And if they don't do that well, then they should just deal with the fact that they have this condition that is really their fault. The problem with that entire thing that I just said is that that's all false. And we do know that obesity is a disease. But if we haven't really recognized it as a disease, then we don't treat it as a disease. That means our clinicians, our physicians, our nurse practitioners, our physician's assistants aren't trained to even address it as a disease, despite the fact that it causes over 200 other disease processes. We treat the downstream impacts of obesity, but we don't treat the obesity itself. And so I think that is where the core issue is the recognition of obesity as a disease. And since we don't do so, even though we know the pathology, we know the pathophysiology, we're going to continue to fail our patients.
So just recently, there was the announcement that a new drug appears to be highly effective, over 21% reduction in body weight. The drug is tirzepatide. That's correct. Tirzepatide, right? It's a GLP-1 inhibitor.
Yes.
So tell me more about this medication and what is its path for weight loss?
These medications act on the brain, and we know the brain is the major organ that regulates weight, particularly the hypothalamus. And so this sends signals to the brain via a pathway called the POMC, or the pro-opiomelanocortin pathway, that tells you to eat less and to store less. And when you ramp that up, you can imagine that can be very, very potent for individuals. And that's why we see that really high degree of weight loss that we see with patients with this medication.
So this drug, as you said, not yet approved for weight loss, but there are others, Wegovy and several others that we might be able to talk about.
Right.
You have a concern that these are not more widely available to patients. Tell me more about that.
So the out-of-pocket costs, if you're looking at these medications, and we don't really know the price point yet on tirzepatide, even in the type 2 diabetes space, because it hasn't yet hit shelves here in the US. But if we're looking at Wegovy, average price point is somewhere between $1,500 to $1,600 US per month. That is quite exorbitant as an out-of-pocket cost for patients. If the medications are not being covered by insurers, you can imagine that cost will be prohibitive for individuals, because most people don't have necessarily $1,600 extra a month to use for one medication. And so that's where we're running into issues. There are a few private insurers, including those in the Commonwealth of Massachusetts, where I reside, that have decided to cover this broadly on their insurance plan. So all of the private insurers at the high tier plans here in Massachusetts do cover these medications, but we are an exception. There are very few states that follow that. And I think a lot of it really has to do with Medicare not covering anti-obesity medications at all. We know that in the United States, Medicare sets the standards for coverage of medications. And under Medicare Part D, here in the United States, anti-obesity medications are completely excluded from coverage. Medicare sets the standards for private insurers. It sets the standards for Medicaid. And so since they have yet to allow coverage of medications, I think this is why we see the downstream impact here, at least in the US, of basically limited to no coverage for patients with obesity.
So that makes no sense to me. If we're able to get obesity under control, we reduce the risk of cancer, heart attack, stroke, orthopedic joint damage. I mean, the list goes on and on and on. We save money, don't we?
So you're preaching to the choir here. So I am a strong proponent of us. Let's treat the disease that causes all the things you just mentioned, Lee. I think that's really, really important. And I think that people are unaware of the fact that we can do that. I can tell you it gives me immense pleasure for my patients that I am able to use these medications for when I'm able to delete diagnoses from their chart. I can think of no other area of medicine where we're actually able to delete diagnoses from patients' charts. But I might be deleting arthritis. I might be deleting sleep apnea. I might be deleting type 2 diabetes and cleaning up their lists such that the biggest problem I might have is figuring out how do I get paid to see the patient that has resolved their chronic diseases. I think that's a really good problem to have and something that I have to deal with, because if I've gotten the patient in good health and actually a pathway to reduced long-stream costs, like let's say a patient had a heart attack, think about the costs that are associated with that. We aren't thinking about all of the unfortunate repercussions for untreated obesity, and those chronic diseases that you mentioned are just a few of, the hundreds that we know exist.
Yeah, for a physician to put themselves out of business is a good thing for the patient. So yeah,
I like it. That's my goal in life, is to put myself out of business in terms of seeing patients. I don't think it'll happen in my lifetime, but let me tell you, if I did that, I would know that I came here and did my job that I was supposed to do.
So what is the experience of using these medications? It's a daily injectable, or not daily, but a weekly injectable, right? A pen style injection. So you do it at home.
Yeah. Right.
And what side effects are there? How do they actually cause that weight loss to occur? And how soon do I notice the effects?
It varies from person to person. I think that's the really key thing when I'm talking to my patients, is that there's a wide distribution of response, where if you're looking at the tirzepatide drug, average was about 21% weight loss. Semaglutide or Wegovy, we're talking about 15%, but then there's a wide spectrum. So you may have some people losing 30 to 35% of their weight, and then another group losing only 7 or 8%. And a lot of that just has to do with that person's biology and how their biology is working with the medications. But what happens is the patient will give the medication as an injection once weekly, usually somewhere in their abdominal region, because that's where we carry some more fat, right? That tissue that's right below the skin surface. And then you just kind of push, and then it gives you the amount of medication that you need. It's a gradual titration up to the treatment dose for these medications. And the number 20th side effect is what I tell my patients is nausea. GI side effects are the most common side effects. And by GI, I mean anything in the gastrointestinal tract. So nausea is by far the most common side effect. Other side effects people might experience are things like constipation, or some people may experience diarrhea, so loose, watery stools. And so those are kind of the more key side effects that people will experience. But I would say, hands down, nausea is the most common, affecting a little over 40% of individuals as we dose escalate. Now, once we get to a kind of a treatment dose and maintain them at that treatment dose, we notice that the symptoms start to abate. And even as they get used to a particular dose, which they're usually on for about a month before moving up to the next dose, they'll also notice that those symptoms start to wane. And then, of course, we introduce the newer, higher dose.
So is this a medication that I should be talking with my primary care doctor about? Is this a medication that I discuss with my my endocrinologist?
So the goal, I would say for me, is to make sure that primary care doctors can, use these medications, prescribe these medications. If we look at here in the U.S., where we're talking over 120 million people with obesity, and there's only, let's say, less than 100 of us that are fellowship trained. That's just not enough people to go around, right? If we look at those that are, board certified in obesity, we're talking about 4,000 physicians, still not enough for over 120 million people. So we need primary care docs to really take some ownership in this space. Obviously, endocrinologists, obesity medicine physicians like myself are going to be very acclimated and aware of the use of these medications. But like I said, I need this to be in the community. And for kind of those more complex cases, those cases that may be refractory to just one agent, et cetera, those would be the cases that would be more suitable for someone like me.
So walk me through this. As a patient, I've tried everything. I still can't get the weight off. How do I have this conversation with my physician? If he tries to talk me out of it, tell me I'm not a good candidate, what then?
Well, so I think that, as a patient, you have to be empowered. You have to recognize that just as we use medications to treat any other chronic disease, whether it be diabetes or high blood pressure, or even something like eczema or something like this, we have medications that are evidence-based and proven, peer-reviewed journals galore, data that indicates their ability to be effective for patients. And so I would say to my doctor, look, doc, I've really honed in and focused on my diet and lifestyle for a long time, it appears as though my body is resistant to any shifts in terms of weight. And I'm really also concerned about maybe other chronic diseases that I'm struggling with. I'd really like to explore the use of anti-obesity medications. And I'd love your guidance. And if you are unable to guide me, if you can point me in the right direction, because this is something that I do plan to pursue. So I think, saying like, this is what I want to do, I'd love for you to be a part of this journey. But if not, I will pursue my care somewhere where I can get really high level care in this area.
So let's talk about that. What is the challenge that keeps me from losing weight? We've seen the stories. We all know someone who really has struggled, tried very hard, and just can't get their weight under control. What seems to work?
Well, it's a variety of things. I think that the key thing is precision and personalization of therapies. Like I said, even for these medications, which are, considered to be the game changers, et cetera, not everyone's a responder. So I have to listen to the different things that may have led this person to gain weight. Maybe it was a strong genetic predisposition to obesity. We know that if you have parents that have obesity, you have a 50 to 85% likelihood of having obesity yourself, even with optimal behaviors surrounding diet and exercise, for example. So maybe that was an issue. Maybe it was hormonal changes, like when someone first got their menstrual cycle, or pregnancy or menopause. Maybe those things shifted someone into having excess weight. Or maybe they were on medications used to treat other conditions that cause weight gain. I mean, we keep going on and on. But when I'm doing my initial appointment with the patient, I'm trying to get a sense of all of those things that may have been likely contributors and begin to address them one by one. But I don't necessarily know what therapy is going to be effective for them. A lot of trial and error often goes into the work in terms of determining, hey, this is the right medicine or medications, plural, and that these things work together to ultimately, lead to success. The key thing I think we have to recognize is that the brain has decided what it wants your set point or set range of weight to be. And so what happens is, let's say you're 250 pounds, your body wants to be 250 pounds, but let's say you want to be 150 pounds, but your body is going to do whatever it can to defend that set point. And you can do things like cutting calories and doing all these things. And acutely, in the immediate, time frame, you might lose weight. But then you're like, wait a minute, why do I always gain and then get above that set point? I think I'm going to think of the body as like a gas tank. So if your gas tank is already really, really large, the body's going to do whatever it can to compensate to keep the gas tank full, meaning keep you at the weight that it wants to be. And as we try to do crash diets and what we call weight cycling, something that we don't sustain over the life course, we end up pushing that set point or set range higher and higher over time. So the goal is to find something that works for the patient, and maybe several somethings that work for the patient, and to sustain it over the life course. That is when we are going to have success.
I want to go back to stigma for just a moment and share with the audience that when I contacted you, I shared an incident of seeing two obese women walking through a parking lot and referred to them in my email to you as morbidly obese. And you snapped back in a positive way, not a negative way, but you called me out on that. So tell me more about the shift in thinking that we really have to get through, not only on the street, all of us, but also everybody in healthcare.
Yeah, so I always talk, and I usually will open a lecture or anything that I, say, and I'll tell us to eliminate two words. And the two words that I want us to eliminate universally are the word obese. Obese is a label, obesity is a disease. So you would never call someone an obese person. A person has obesity. So that's one framework or shift in thinking. They are not defined by it, yet they have it, and we can help treat that disease. And let's look at this term morbid that we use when we talk about it in terms of obesity. We don't call it morbid COVID-19. We don't call it morbid cancer. We don't call it morbid heart disease, yet we lose people from these things each and every day. And so you can imagine that when we use this term morbid to explain obesity, that we're saying that, oh, you only die from the obesity, but not all those other things, which we know to be causative for many deaths here in the US and around the world. So we want to remove that term. So instead, we would say a person with severe obesity. And language matters, because when we talk about a person with obesity and not an obese person, they start to recognize that, oh, wait a minute, this doesn't define me. This is just something that we have to treat, just like we might have to treat their depression or their heart disease or whatever else it might be. And so the language is really, really important. We call it people first language. The person is first. The disease is secondary to them as a person. And making sure that we understand that really helps us to move and shift the blame and shame game away from the patient themselves, which often has something in their body and their physiology that makes them carry more adipose. Adipose is fat than one other person. And it doesn't mean that one person is superior to the other. It just means that one person's body stores more fat. And then why is that? And then how do I help reduce that burden so that they can live the happiest, healthiest life for them?
So do you think the blame and shame game has an influence on whether or not Medicare is going to be including these meds in the formulary? Or is that simply a financial matter that we have to kind of get through and get into the heads of Congress for?
I think it's multifactorial. So I think probably both of those things play a role in why we haven't really seen this shift. I can tell you we've been trying to introduce a bill called the Treat and Reduce Obesity Act into Congress continuously, both on the House and Senate side, since 2013. In case you guys are unaware, we are in 2022, which means that we're almost 10 years into this game of introducing the Treat and Reduce Obesity Act, which does one key thing. It covers anti-obesity medications under Medicare, in addition to providing behavioral therapy for patients with obesity who are under Medicare. Currently in the United States, if you want to work with a dietitian and you have obesity and you're under Medicare, that visit is not covered. However, if you have diabetes, that visit is covered. So you have to get diabetes to then work with a dietitian, which to me seems like we're a little bit kind of further along the path than we should be. And we should maybe address it before we get to the diabetes stage, which we know has a lot of major health implications. But the current paradigm of treatment just does not align with that. So I think that we need to be speaking to our congressmen and women. We need to be speaking to our senators. We need to be driving home the fact that this is a disease. We're not treating it equitably. And when we continue to have this lack of treatment, only 1% of patients that meet criteria for medications for the treatment of obesity in the United States today receive medications, 1%. So that means that I don't think we're doing our job. A lot of people are like, oh gosh, we're spending so much money on drugs for obesity, but 1%, I'm going to say that we're not doing enough. And so I think that we can do better. And I think that Congress can play a major role. And I would say in this 9th year, going into our 10th year of putting this bill forward, that we really need to get this across the finish line.
I think that's a good place to leave it. I will put links below, not only to the bill, but also to some other appearances you've made elsewhere so that people can learn more about obesity and treating it like a disease. Dr. Stanford, thank you.
Thank you so much for having me.